What is intertendinous approach to popliteal fossa? Anybody use intertendinous approach? No? Okay, if you actually feel your tendons, okay, you can actually see it on yourself, and you feel the two tendons. On the lateral side is the tendon of the biceps, on the medial side is the tendon of the semimembranous and semitendinosus. So you can ask the patient to do that, you just mark them, okay, and you go just at the midpoint of these two tendons, around 7 to 11 centimeters. And the nerve is lying perfectly at the center of these two tendons. You go in, and you don't get the response you want. Okay, but you start getting twitching of the biceps femoris. You know that you're too lateral. You're too medial, you'll see twitching of your semitendinosus and semimembranosus. And you know it's too medial. Okay, at that point, it's actually very, very easy to just come out of it. You need to angle your little pipe just 2 degrees. Because now it's deep, okay? You change the angle by just 1 degrees, you go off the tangent. You need to come out and angle it sort of into the center. Okay, it's a very easy approach. And you go and try it. All you need to do is ask someone to hold their leg. And because if you don't have an assistant, what you can do, you use the arm support, the counterpanes. Okay, you can actually put the counterpanes, tie the leg to it. Okay, rest the leg on that, and you can actually use that. Because sometimes your assistant gets tired, their hand starts shaking. When your hand starts shaking, okay, they can actually use the counterpanes to do that. Once you get expertise, then you'll be able to do it within minutes. It's a beautiful approach. Volume 4 of the popliteal fossa is around 15-20 mm. Okay, don't again shy away from the volume. It is the block you need to do for any surgery for anything below the knee. So tibial fractures, for your fibular fractures, ankle fractures, 0.5, 0.375 is fine. So coming to the mother of all blocks. These are called the mother of all blocks, lumbar and sacral plexus. A lot of people fear it because there are serious complications associated with them. But today I will enlighten you. You will all become the Buddhas. Because having done now thousands of these blocks, we have not had any complication. We have detected the complication even before it occurred, even before it could actually happen. And I'll tell you how. But before that, we'll go through the lumbar and sacral plexus. So first, the lumbar plexus. I mean, we have discussed it briefly. So it originates from L1, L2, L3, L4. Femoral nerve and ocular nerve actually have the same origin, L2, L3, L4. One comes from the anterior division, other comes from posterior division. Posterior division femoral nerve, anterior division ocular nerve. Lateral canaries come from L2, L3. And I think we will leave the L1, but L2 actually gives component ejector femoral. It's not part of the lumbar plexus as such. But L4 and L5 give a lumbosacral trunk to the sciatic block, to the sciatic nerve or sacral plexus. Okay, these are the dissections where you can actually see the nerves originating. And what you observe here is that they are very close to the transverse process. And because they are very close to the transverse process, you're basically very near to the roots. And I will tell you the importance of that. This is also a very important image. If you look at these nerves, okay, so what you're seeing is that this is the longitudinous nerve of the thigh, which is coming near the anterospinal spine. Look at it, it's given off almost halfway through the your psoas muscle. Whereas the femoral nerve comes out on the lower part of the psoas muscle, whereas the obturator actually goes almost through the muscle itself and lies on the medial side. And that's why there is nothing called 3-in-1 block. You cannot give 3-in-1 block because local anesthetic cannot go to the obturator. When you do femoral nerve block with large volumes, you might be able to block the femoral for sure, little continuous maybe, but obturator nerve never. So there is nothing called 3-in-1 block. As far as indications are concerned, lumbar plexus on its own can be used for femoral surgeries, but should ideally be combined with the sacral plexus blocks or sciatic nerve block, because posterior part of the femur itself and the muscles are supplied by the sacral plexus. Or because the L4, L5 provides the lumbosacral trunk, so even if you use large volume with lumbar plexus, you can actually block some components of the sciatic nerve. One thing. Second thing, in certain thing which we discussed, Hetal was there, he was one of them, he said, sometimes I do lumbar plexus block, and when I try to do sacral plexus block, whatever technique I use, I don't get twitches. He says, my landmarks are fine, this is a thin patient, don't have twitches. So why I started investigating that, say, why should it be? So what we did was, we did a lumbar plexus block, and in a series of around 20 cases, we actually tried to do that where we didn't get twitch. And so we said, let's scan the sacral plexus, and to our surprise, there was local anesthetic already around the sacral plexus. And no doubt, in some cases, it works beautifully, especially if you are at L4 level. If you're doing the lumbar plexus L4 level, use large volumes, invariably you'll get local anesthetic around the sacral plexus as well. And you can get away without actually having to do with the sacral plexus. So don't be disheartened if you don't get actually a twitch at the sacral plexus when you've already done the lumbar plexus. So surgery, any surgery around the hip, lumbar sacral plexus is a wonderful block. The many approaches, Winnie's approach was to actually mark the spine. So you mark the spine, then you mark the two-fuse line. We know that two-fuse line passes through L3, L4 interspace. Next, feel for the superior iliac spine, and draw a line through that which is parallel to the first line that is going to the spine. And you get the intersection of that. What is the disadvantage here? Any disadvantage? Winnie, big man, he's described so many approaches. Why would that be a problem? One thing is too lateral, yes. Anything else? You don't know where you're going to go. It's like this where somebody putting a spine and coming up on you. You go in and in. You took a big needle because somebody said they only get 15 centimeter needle in their hospital. So somebody was doing a block. I said, what size needle is that? I have 15 centimeters. I said, why are you using it 15 centimeters? All you needed is 4 centimeters. He said, that's what is provided to us. He said, that's what the supplies come. Okay, fine, that's okay. So you do 15 and you keep going in, and next thing you are into the kidney to the other side, everything like a kebab. Okay, you don't want to do that. Okay, so there is no end point. We say that I need to find the plexus at this level. And you will be surprised that in different patients it could be as deep as 10 centimeters. This is another approach. So Chayen's approach is similar to your paravertebral. He said, no, it's fine. We'll do it as a paravertebral. So what you feel for the spinous process, you go 4 centimeters from that. hit the transverse process, walk off it inferiorly or superiorly, just like you do for paravertebrals. And so that is Chayen's approach. The problem with this is too medial. And if you have too medial, you're going to the roots, and the roots actually have got a dural cuff. You go into the dural cuff, you cause a total spinal. These are volume blocks. Use at least 20-30 mL. You give 20-30 mL, you can do a neurosurgery on a patient. Total spinal. It reaches the head. Okay, so Winnie's and Chayen's approach. So I told one is too lateral, one is too medial. So in 2002, Capdevila described this approach. Okay. So the landmarks are the same. So you have first line through spine, second line through the diffuse line, third line parallel to the first line, going through posterior spine. But in this, what we did actually mark the 2/3 and 1/3, and you go a centimeter away from it. Now you know that when you're looking at diffuse line, you're at interspace. But if you go cranially or caudally, you'll be hitting the transverse process. Okay, and that is the beauty of this approach. You know that once you hit the transverse process, and from studies we know that the nerves lie around 18 to 20 millimeters from there. So you don't need to go more than 2 centimeters. If you're not getting a twitch at 2 centimeters, you need to realign yourself, look at the landmark and say, maybe I'm in the wrong place. Okay. There's another approach which is actually, I don't think it's clearly described, but in this what we do is you actually mark the L4, posterior leg spine, join the line, and the junction of the lateral 1/3 and medial 2/3. So for any lumbar plexus, it's lateral 1/3, medial 2/3. Go there, hit the transverse process of the L5, and you need to walk off cranially. So this will actually give you both lumbar and sacral plexus if you use good volumes. And this is where we are seeing how the nerves that CT scan again. Winnie's approach is too lateral. Why is it going back? The Chayen's approach is too medial. Okay, and Capdevila's approach seems to be actually sort of a much safer approach for any of them. This is actually a nice image in which a lot of studies were done, and I thought I had actually taken away the transition. Okay. So if you look at the distance to the transverse process, it varies on the patient. So, Tim Mataji, Modi Mataji, Patri Mataji. So it is all that can vary. So the distance to the transverse process can vary. But if you look at the distance once you hit the transverse process to the nerve, actually doesn't vary. So thickness of the transverse process is depending, doesn't matter how big you are, is almost constant, 18 to 20 millimeters. So that's the safety of the Capdevila approach. So hit the transverse process, whether using 15 centimeter needle, 20 centimeter, doesn't matter. All you need to do is walk off, and walk off by no more than 2 centimeters. 10 to 20% here and there doesn't make much difference. Okay. So you hit the transverse process, walk off it, okay, and you will get the stimulation. Like the same thing here, like it shows, it's very close to the transverse process. Okay. So you can walk up cranial or caudally, doesn't matter, but you need to be at the edge of the transverse process. Like the transverse process is like your thumb. Right? Now if you're in the center, and you see that you're actually having to walk off quite a lot, you're going to go off a tangent. Like you don't want that. But you want to do the same thing happen, and you don't get a twitch. You need to be at the corner. Okay. You want to be actually at the lower end or the upper end, so that you can actually just come out and glide off the transverse process. and then it will be around 2 centimeters. But if you're trying to get it to that, you might actually not be getting, say this is L2, you might be going to L4, L5. Okay, going